Thanks. And I'm really, where's Teresa? Where is she? I'm so excited that you're here, another Teresa. It's awesome. Our names are a little different. And you should have known there were going to be multiple ones because look, they gave us more water bottles than normal. So we're kind of shaking up the WIP a little. What we wanted to do was really bring the people that were intimately involved in this project up here so you could see them, they can talk to what we did, because the success of this project is a reflection of a very large team, of which these are just some of the members. This is a project that has been completed. We're going to walk through what we did, and then at the end we're going to talk to you about the next parts of this. So these are the presentation goals. I'm not going to read them to you. You can get a copy of the slides, but really what we wanted to do is identify for you through this process the lessons that we learned that can inform future work. I'll take the opportunity right now of saying, as we work on the LOINC strategic plan, also we've been able to engage and utilize the lessons we learned with human-centered design, and Jennifer will be talking about that a little. I will tell you my mantra at the end of this work was people, process, technology. I could do that in my sleep. Somebody could wake me up and I could now really understand what human-centered design is all about. This is the background. For those of you, well, not everyone may be familiar with IHS. Actually, I would argue that Indiana, the reason why this state is named that was because it was really the entryway to the West, for those of you who might not remember your history. I spent 25 years working with Indian people, American Indians and Alaska Natives, as an active duty public health service officer. The disparities in American Indian and Alaska Native tribes continue till today. The highest disease burden, the lowest life expectancy, the least access to care, the lowest amount of resources available to provide care. At the same time, despite how depressing those symptoms may be, there are major changes that are happening in Indian country. The concept of self-empowerment, the concept of tribal undertaking their own healthcare system is transformative. Obviously, it's an opportunity for us to learn, not only for American Indian, Alaska Native communities, but for other underserved communities. The concept of how do we work together to empower a community, and hopefully you'll see that throughout what we present today. And you can see our guiding principles. We felt really strongly before we started this work that we needed to figure out what the principles were that were important to us. These were co-developed with the sponsor of this program, which was the CTO's office at Health and Human Services, as well as Indian Health Service. Oh, thanks. And you can see what they're reflected here, which is really this people-centered, be impactful, use data in a way that is important, and make sure that we are honoring and respecting not only the communities that we entered into, and Matthew will show you a slide that shows everywhere we went, which was most of the country, but also the individuals that we encountered as we went through our work. This next slide shows you our focus areas. I have to say, there's days I can't believe we did all this. So this was 12 months, and I was struck, Teresa, by what you previously presented, all these different venues and opportunities and pathways that you engaged in. It's somewhat similar to our work. We had very defined areas that we started with, and we were able to work in all of them. At the end of this, we had 8 major artifacts that have been shared with the department, and I'll go over those with you. But suffice it to say, if you look at this, and you look at how we started, we were swarmy, and you'll see that that's one of the lessons learned, how to tolerate ambiguity and swarming in a major project. But we're going to focus on some of these today. We won't go over all of them because we don't have enough time. And we did take a 3-pronged approach. You can see this here. Once again, people, process, technology. We can envelop almost everything within that. Almost every organizational construct you come up with in terms of informatics can utilize that to display, discover, innovate, and finally implement. And you can see here our 3-pronged approach. And today we're going to talk about some of these, not all of them, as I mentioned. And with that, I'm going to turn it over to Jennifer, who's going to talk about the development life cycle.
Thanks. So as a computer scientist and as a person who specializes also in human-centered design, I think when we approach a project like this, it's a technical project, we have to figure out how we're going to approach it. So on the slide, I have listed the typical systems development life cycle. I mean, yes, there's different names or whatever, but the point is it's not necessarily linear like it's usually described. And so we needed to think about how we're doing a technology project and how that would work. So then as we think about human-centered design and how to include the people in such a project, we look at the Stanford design thinking model. There are also other models for this. But the thing that's different about this and about the typical computer science approach is that this one really focuses on empathizing and understanding and using or working with the people who are impacted by the problem to actually work through the problem. So you have these two different models and these two different ways of approaching a complex problem. And we can think of a complex problem as looking like at the beginning, it's kind of fuzzy. So this project was fuzzy in the very beginning as we think about what does it mean to modernize Indian Health Services system? What does that really mean? Modernization is very fuzzy. So as you think about a trajectory of a project, there's going to be lots of iteration at that upfront point to even figure out what it is that you're trying to accomplish and what does it really mean to modernize. So this is kind of the process that we envisioned would happen, and the later stages would actually be, okay, once you've kind of settled in on a design, then you iterate through that. So how do you actually put the problem and the other disciplines together? So this is kind of a way that I've tried to depict it is for the IHS project, we were actually focused pre-systems design for the most of the project. So what we were really focusing on is really trying to understand the people and the context and develop that empathy for what are the challenges that they actually face. Some things that I didn't expect to find out as we're developing this empathy is that to actually get cell service, to get a consult, you actually had to run out of the building in one case to find a particular spot in the parking lot to stand to get cell service. So there are just different challenges that we needed to understand. And so to put this together, we were focusing mostly on the blue part, understanding the context and framing based from the user's perspective, how should we move forward in understanding what does a modern health information system look like for Indian Health Services. So we used the Stanford model kind of to think about and empathize with people as we're doing that part of the project instead of what typically happens is more the focus, and I think we even had a presentation last week that was more people or human or user-centered, that was more focusing on the typical parts of a technical project where you're working on requirements and design and developing an interface and evaluating. That would be a typical place where human-centered design has been used in our discipline typically. We're pushing it out and using it more in how do we do this understanding and framing of the project. And so that's one thing that makes this project really unique. Oops. So, sorry. So as we think about that, we had to develop different methods that we were going to use. And one of the things we wanted to do is make sure that whatever we're doing, we're listening to the voice of the people and the voice of the people that are actually caring for the patients and hearing from them. So we developed many different methods. Most of these methods were really deployed during site visits, which is what Matthew's going to talk about. But the methods focused on really open-ended questions to get the conversation started. So we tried to remove ourselves from the situation and our preconceived notions, and even for Terry, some of her pre-experience. Try to wash that out of your brain and ask like you're a new person to really listen and understand what the people on the ground are experiencing. So we use these open-ended questions and try to gather information. And then we also use methods that I'm not going to explain today to do analysis and synthesis of the information that we got. If you want more information, you can see me afterwards, but I'm going to turn it over to Matthew to describe more about the site visits.
So as you can see, we went to 25 different sites in less than a year. We should have had 12 months, but we had to deal with the government shutdown. So we crammed them all in about 10 months. The Indian Health Service is divided up into 12 areas, and each of these areas has a unique group of tribes that they work with on a day-to-day basis. Facilities operate under one of 3 delivery care models. There are IHS direct sites, which operate based solely on IHS policy and funding. There are tribal sites, which are affiliated with a specific tribe and operate under their own governance. Urban sites, which are one specific tribe and operate similarly to tribal sites. The structure of these site visits generally followed the same format. Most staff were welcoming and super excited that we were there. Some were a bit dubious. Similar efforts had been executed in the past with little to no payoff, so setting expectations was important. Lots of insight was gained through tours of the entire facility, even areas that may not have been directly related to their HIT, their health IT, excuse me. It helped us connect to their environment and their viewpoint. And it should also be noted that depending on which site, Indian, tribal, or urban, there was a noticeable variance in participation in the general tone based on how the facility operates. So from these site visits, we used the model that Jennifer spoke about, and we came up with these 5 user insights. So these are the 5 areas that users feel need the most attention moving forward with a modernization effort. These insights address issues with the system itself, which you can see in the usability and the interoperability, but also address issues with staffing shortages, support processes, and training. They give a deeper insight into why RPMS has become what it has. And I will hand it over to Joe for another method that we used.
Thank you. And so another way that we were engaging the end users in this is that we sent out a survey, a data call, and we ended up getting responses from over 1,000 HIT end users. We were asking them about their HIT satisfaction, what their functionality needs were, and how ready they thought the organization was for change. And what we ended up getting back was that there is a high amount of dissatisfaction with the system, and a lot of our users feel that there are significant improvements that are needed. But even beyond the system itself, the sites that are using RPMS often feel that they don't have the necessary hardware, and the vast majority of our users were saying that it is the time for change. And so our takeaway from that was, first and foremost, we need to capitalize on that desire for change and make sure that we leverage that. But in addition to that, we can't just modernize a system itself. We need to be looking at the infrastructure that our users are working within. And we also just have these 3 areas of end user experience that we need to fix. We need to make sure that they have interoperability and that they can do reporting and that they have good usability and data entry. In addition to that, we also did a little bit more of a independent review of RPMS, a little bit separate from the users to try to get a little more direct with it. And what we were doing with that was looking at the RPMS architecture. We were looking at the application interdependencies, the multiple GUIs, and try to figure out what are the opportunities for modernization of RPMS. And what we ended up finding from that was not very good things. You can see a lot of inadequate squares up here, and we have a couple that are operative, but for the most part, RPMS is not a system that is really going to be usable in today's environment. And so this technical review overall found that, one, the RPMS code is not going to be supportable over the next decade. The user experience is disjointed and can lead to a high risk of error. The system itself is very hard to maintain, especially with our hardware and infrastructure, and the organizational support, training, and resources are just not sufficient either. So as we start moving into the current state of RPMS, we're trying to start thinking, okay, what can our strategy be for modernization? And we start thinking, what can we learn from others who have also modernized their HIT? And so we started off with a literature search to try to find out these experiences of people who have gone through this before, and there's really not a whole lot. And what there is out there is for more smaller organizations, not for large healthcare enterprises. So we went out and we asked them ourselves. We found both Indian Health and outside of Indian Health organizations who have gone through this, and we just started asking them, what was your process for change, and figure out what we can learn from it. And some of the big takeaways from this was that when they were deciding to switch and selecting a product, the clinician involvement is obviously very huge, but there's different ways of going about it. For our Indian health organizations, it tended to be more of a community-centered approach, whereas our non-Indian health organizations tend to do more of a board-governed framework. And when we asked them about how successful their modernization was, they said it was very successful because they saw improved quality of life for their clinicians and improved quality of care for their patients. And a big reason for this was interoperability, that they were sharing data with each other, and that was improving care. And then along with that was the financial benefits that come with modernization. And I'm not going to walk through this, but I also put the phases of modernization that we were able to extract from our interviews that show here's generally what an organization is going to have to go through in order to modernize. And next I'll throw it to Shannon for some other stuff.
Hey, thanks, Joe. So I'm going to talk about the role of a technical advisory commission, a TAC, in this project. So as has been described, so the core focus of this project, the method that we used was applying human-centered design. So the TAC is related to that, right? So we established a TAC that supported this approach. And the TAC was charged with reviewing data that we gathered throughout the project's course and then provide their own recommendations based on that data, and also based on their experience with the system. So Paul Beyondich and Jamie Thomas and Michelle Cox, they led the facilitation and organization of this work stream. So they're in the audience and can address questions during the discussion if you have it. So we used a deliberate group design and vetting process to form the TAC, and we focused on identifying individuals for the commission with considerable skills and experience in health information technology, also extensive experience and skills with Native communities, either as tribal members themselves or that they had a deep understanding of this population. We also looked for really strong personal qualities, such that they had high integrity or that they were willing to ask really difficult, challenging questions to each other. So we were really lucky to convene this amazing group of individuals that you can see up on the screen. And these folks volunteered their time to be part of this, so we're really grateful for their participation. So here is the full list of recommendations that the TAC provided to Health and Human Services and ultimately the Indian Health Service. So these were established through a consensus process. I'm going to highlight a few of the recommendations, but again, feel free to ask questions during the discussion. So the first recommendation, the HIT modernization effort should include and ultimately benefit the entire ITU, which Matthew explained, ecosystem. So that seems really obvious, right? That nothing should be developed without the involvement of those that it impacts. But I think we all know that what's obvious sometimes is not always done in practice. So there are self-governance principles which support tribal authority. And the TAC recommended that these be implemented in order to stop the continued oppression, Terry kind of talked on that a little bit, and disregard of government-to-government relations between the federal government and tribal communities. So Native communities should be allowed to determine roles that entities both within and outside of Indian country will play in the implementation process, so that they're actually determining who's involved and who are the players and what's going on versus the federal government determining that process for them. Recommendation 7. So to quickly establish a project governance model for the modernization effort itself. So the TAC recommended that effective governance is more important than any specific technology platforms that are selected. The TAC advised that the formation of a governing body that interfaces regularly with they interface regularly with a stakeholder group. And that group can and should be much larger and inclusive to effectively represent the inherent diversity of Native communities across our nation. So the TAC ended up drafting a governance charter that wasn't an originally defined deliverable of our project, but drafted a governance charter and submitted that to Health and Human Services. And then I'll talk about recommendation 14, which is about money. So as Terry shared early in the presentation, or at least was up on the screen, the Indian Health Service is chronically underfunded. I can't stress that enough. So in order to modernize appropriately and ethically, there needs to be aggressive, upfront, and ongoing financial support of the modernization effort with an eye to long-term total cost of that ownership of the system and modernization. So the TAC also did provide a timeline for all of these recommendations. You can see there are a lot. So they're not necessarily in chronological order of that timeline, but we provided that as well. So this was a separate deliverable, but really interconnected to our overall project recommendations, and Matthew's going to share those with you guys now.
So these 3 perspectives, the user, the technical, and the expert, were synthesized into these 8 recommendations which were put into a findings and recommendations report. These go beyond merely redesigning or replacing RPMS. They recommend a holistic approach that will not only address the current issues facing ITU, health IT, but allow it to adapt to future needs and changes in the industry. And that's it.
So we're going to talk about next steps, but I want to step back a second. So the HHS CTO funded this project, and you'll see in the last slides who they funded. We were a sub to the prime, but we did probably 98% of the work, which was fine. We had agreed to that up front. The whole point of this was to really help Indian Health Service figure out what to do. However, it's easy for a federal agency to figure out what to do if there's resourcing. The IHS is, as Shannon said, significantly underfunded. It continues to be underfunded. And you're going to see a little bit about that in these next steps. The beauty of us doing this project as opposed to the federal government doing it itself is that we have the opportunity to do advocacy. I think when we do research and we do evaluations, sometimes we forget that the opportunity exists to be advocates for what we believe should be the change that we want to see. The one comment we heard repeatedly from the tribes was, "Nothing for me without me." That's a saying I'm sure you've all heard from other groups as it's been formulated in many historical contexts. In this context, we were the outsiders. Despite my years of Indian Health Service, I'm not Native. We engaged closely with Native people to ensure that we could adequately represent their needs. But for us to just deliver what you saw is, in my opinion, would have been a waste of our year. We spent a lot of time, everybody up here, many people in the audience, you're going to see, went above and beyond. We delivered on time, above expectations, and having been a federal person for years, I've never seen a contractor deliver as much as we delivered for what they gave us. So it's a shout out to Regenstrief and the team that worked here. But we engaged in this project not just because it was important research. Is it important to know how to change an EHR system? Are there important steps that people have missed? Are there opportunities to help make the system more efficient, effective, and respond to the analytic needs? Most of us engaged in this because we really wanted things to be better. So we took it upon ourselves to say that advocacy was really important. And we can talk briefly about that here, and you can see it. What I know from my years on the Hill is that what the staffers want is an article in Health Affairs or a blog in Health Affairs blog. And that's because that's what they carry with them. They print it out and they show it to their senators or their representatives. We've been lucky enough, we wrote a Health Affairs blog. It's been accepted for publication. It hasn't come out yet. For those of you who track American Indian, Alaska Native issues, you may be aware that there's been a lot of fairly distressing investigative reporting that's gone on in the last 2 months, most of it reported in the Washington papers. Our hope is that our blog report, while it is discouraging about the current state of affairs, can be used by the staffers to encourage the federal government to fund what needs to happen. You may be aware that DoD and VA are moving to Cerner. The price tags on those are billions of dollars. IHS serves 25% of the people that the VA serves with a budget that's about 8% of their budget. The budget right now for modernization for the health IT system at IHS, which is in as many places as the VA, though I would indicate that the IHS rarely runs hospitals that are tertiary care centers, is approximately $200 million, where the VA IT budget for the modernization of Cerner, as you know, is in high single, low double billion-dollar numbers. So our work will be in vain if there's no embracing of it and the ability to move it forward. So you can see, because of that, our next steps. We engaged with HHS, we got their endorsement, we got the IHS endorsement, which is a pretty typical, for those of you familiar with the federal government, a pretty typical way to move stuff forward. We expect that there will need to be ongoing embracing, engagement, endorsement with the tribal communities. I will say Carolyn Crowder, who worked closely with us on this as a tribal member, she and I have worked together for 25 years. We both thought that this was our last shot. If we couldn't convince people by doing a research, in quotes, evaluation of what was needed for IHS to modernize their health IT system, we weren't sure what would work. So we are still hopeful. We do know that for those of you who track government budget, the president's management agenda does not come out with funding for this, which is distressing, but we hope that it will happen in the future. On a more light note, the first lesson we learned is don't do a contract if the government's going to shut down. Try to not do that. So that delayed us about 4 to 6 months. We were able to compensate for that. I do want to call attention to Jennifer's slide. If you remember her squiggly line, she did that one day up in our little cubbies when I think we were all like, what the hell are we doing here and how are we going to get out of it? So Jennifer captured that in her beautiful model of us swarming here. And the beauty is that by the end, you did see it all came together. So the ability to tolerate ambiguity, to not know what you're doing when you start, to be able to swarm and not kill each other, I think is really important. Our ability to create a team that did really well was critical. And you can see here some of the roles we had. And that's why I think it's so important, especially in this project, to give homage to this team. I may have been the person that got some face time on it, but everybody up here, including lots of other people, are the reason why we were successful to deliver. The artifacts have been released by the Health and Human Services CTO office and are available. Many vendors have been looking at them. People are looking for opportunities to make money. We just want them to do opportunities to do good, which would be really important. So work for impact. I think that was one of the major things we focused on. I think global health, which most of us are from, is really one of the endeavors that embrace that. This is an example or parts of the team. Jeff Orville, I know Jeff is here and I really need to thank him because at the last minute, man, he bailed us out, just like everybody else. But you can see we had people from everywhere working with us. It was quite a successful project. I think we all breathed a sigh of relief September 13th. September 15th, September 12th when it ended, and we did present it to the HHS CTO. There is future work to be done. there's lots of things that we developed and that we can leverage. We hope, for instance, that the TAC stays together. We hope that other people are able to use our work for other underserved populations in the US and abroad. And with that, I really just want to re-thank the team. Thank Regenstrief, because many people at Regenstrief had to touch this project. It was a highly visible, highly accelerated project with a lot of money and effort flowing in and out. So thank you.